Okay, the divisions of the peripheral nervous system. You have a somatic sensory division that you see on the left here, which involves all those sensory neurons that carry signals from your muscles, bones, joints, skin, as well as your special sensory organs like your vision, hearing, smell, taste. That's what we refer to as our somatic sensory division. Okay. Remember, this is part of your peripheral nervous system because it lies outside the brain and spinal cord. And then the visceral sensory division, those type of organs receive input from signals from your visceral organs like your bladder, okay, or your GI tract. Okay. Everything that you see in blue here is sensory, okay, whether it's somatic sensory or visceral sensory, but it's part of your peripheral nervous system. And then your motor efferent division, where it's called peripheral because it's outside your brain and spinal cord. It's also subdivided into a somatic motor division and visceral motor division, analogous to your somatic sensory and visceral sensory that we talked about in your sensory divisions. So your somatic motor division include all those voluntary motor contractions that allow you to execute movement. And your visceral motor division includes your autonomic nervous system, the sympathetic and parasympathetic division. So your peripheral nerves are your main organs of your peripheral nervous system. And a nerve is axons of many neurons that are bound together by connective tissues. And they're structured in a very similar manner as to what skeletal muscle is structured when you looked at muscle organization. So your nerves of the peripheral nervous system either contact or innervate the majority of the structures in your body. This is how we communicate with the body organs. Mixed nerves means it contains both sensory and motor neurons, whereas sensory nerves contain only sensory neurons, whereas motor nerves carry only mostly motor neurons. These are also some of the sensory neurons involved in both muscle stretch and tension. Spinal nerves, these originate from the spinal cord and they innervate structures below the head and neck. There's two collections of axons that connect your peripheral nervous system with the spinal cord gray matter. The anterior or ventral root consists of your motor neurons from the anterior horn, and the posterior or dorsal root, those will consist of sensory neurons from the posterior or dorsal horn. And the best way to remember this is look at the image of the spinal cord and the organization of the spinal cord. Okay. So when you look at the spinal nerves, the dorsal or posterior root, it features a very swollen area that houses cell bodies of sensory neurons. Those are called posterior or dorsal root ganglion. You can see it right outside the spinal cord, on either side of the spinal cord. So the posterior and anterior or dorsal and ventral roots will fuse together to form a spinal nerve just lateral to the dorsal root ganglion. You can use dorsal, the term dorsal, or you can use the term posterior. Same thing for ventral, you can also use anterior. So all 31 pairs of spinal nerves are mixed nerves. So this is the anatomical organization of your anterior and posterior roots and your spinal nerves. As you can see, the spinal cord on the left in figure 13.2a, you can see the gray matter, which forms that inner butterfly-like pattern. This is all gray matter because it consists of cell bodies of neurons, whereas the white matter is on the outside and superficial in the spinal cord. Okay, so you can see that posterior root or dorsal root, which carries only sensory fibers, and I will highlight that area here. Okay, so this information is going into the spinal cord, as you can see by the arrow. Okay, whereas the ventral or anterior root will be highlighted in red. This will carry only motor or efferent fibers, so it's going in the opposite direction, as you can see by the arrow. Okay, so this is referred to as ventral or motor information. And then outside the dorsal root ganglion or posterior root ganglion, remember your posterior root ganglion, this area right here, contains cell bodies of sensory neurons. But just past that, the anterior and the posterior root come together and form a mixed spinal nerve, which you see here. Okay. And if you look at the individual axons, you can see the axons are basically shown on that inset where you can see the axon of one neuron, which are your basic fundamental units that transmit your nerve impulses. Okay. So let's look at the organization of the peripheral nerves. Very similar to the organization of muscle, skeletal muscle. Epineurium is your outermost layer of connective tissue. This is what holds most of your motor and sensory axons together. Fascicles, those are groups of bundled axons surrounded by perineurium. Just like you have paramecium in skeletal muscle fascicles, you have perineurium that surround your neuron fascicles. And then each individual axon within a fascicle is surrounded by its own connective tissue, and that's referred to as the endoneurium. So I'll highlight these in red. Endoneurium is what you see surrounding these bundles of axons. Right here, that's called the endoneurium. And then you have your perineurium, which surrounds the fascicles. Remember, that's your middle connective tissue layer. And then you have your epineurium, which lies on the outside, and that will surround all of the fascicles. Like you see here, everything that you see outlined here in red. Okay, and that's referred to as the epineurium. Just like you have epimecium for organization of skeletal muscle fibers, you have epineurium for the organization of neurons. So let's look at the cranial nerves. There are 12 cranial nerves attached to the brain, mostly innervate structures in the head and neck, thus they're called cranial nerves. Now these are not formed by the fusion of both sensory and motor roots like you see in your spinal nerves. And this is what allows for purely sensory mixed or mostly motor nerves, as we'll go through later. So your functions of your peripheral nervous system are integrated with those of your central nervous system. So your sensory neurons will detect the stimulus at the sensory receptor. And then you have a series of events that occur. The detected stimulus then is transmitted along the sensory neuron, either via the spinal nerve or cranial nerve, to the cerebral cortex. When it reaches the cortex, that sensory information then is interpreted, it's then processed or integrated, and then an appropriate motor response is selected for and then initiated. And that's what you see on this next slide here. Your motor response is initiated by commands from your motor areas of your cerebral cortex. So, and that leads to these impulses traveling to the spinal cord, where the neurons then synapse with the lower motor neurons of your peripheral nervous system. The lower motor neurons then carry impulses to the appropriate muscle via the cranial nerve or the spinal nerves, where they trigger contractions. So let's look at the 12 cranial nerves. They're named with Roman numerals 1 through 12. 3 cranial nerves only contain sensory axons, so those are the olfactory for smell, optic, and then you also have the vestibulocochlear, that would be a purely sensory nerve. And then you have 5 cranial nerves contain axons of motor neurons, and those are oculomotor 3, trochlear 4, abducens 6. Remember 3, 4, and 6. These 3 right here, these basically innervate your eye muscles. Okay. Accessory nerve, number 11, Roman numeral 11, this will go to your trapezius and your sternocleidomastoid. So it's purely motor. And then hypoglossal, purely motor. Glossal refers to tongue. Hypo means below the tongue. So hypoglossal is the cranial nerve that innervates the tongue. But it's motor to the tongue. This one right here. Okay. Accessory goes to your back muscles, your sternocleidomastoid, trapezius, which I'll just refer to as the back muscles, and neck muscles, back and neck. Okay, so this is an image of the 3 cranial nerves that innervate your extraocular eye muscles, number 3, 4, and 6. Oculomotor, which innervates 4 of the extraocular eye muscles, your superior rectus, inferior rectus, medial rectus, the inferior oblique. Trochlear nerve, number 4, it innervates the superior oblique muscle, which you can see just on the upper lateral margin of the inside of the eye, this nerve, this muscle right up here, okay, in yellow here. Okay. And then you've got number 6, which is abducens nerve. This goes to the lateral rectus. This is the lateral rectus muscle. And then you have your motor cranial nerves, okay? The accessory nerve and the hypoglossal nerve. Hypoglossal nerve goes to the tongue. And the accessory nerve goes to the trapezius muscle and sternocleidomastoid muscle. Okay, so it allows you to turn your head to left and right. Okay, and then you have the mixed cranial nerves that carry both sensory information and motor information. The facial nerve, number 7, is a mixed nerve. The facial nerve, as you can see from the illustration, it carries sensory information from the face, all 3 areas of the face. The upper eye area, the middle jaw, where the maxilla is located, and then the lower jaw, the mandible. Those 3 areas of the face are going to take this sensory division. Okay, the facial nerve is basically a mixed nerve because it's going to have sensory information for taste and motor information for the muscles of facial expression. And then trigeminal nerve it's also a mixed nerve. It's sensory and motor as well. Trigeminal nerve is a huge nerve. It's sensory to all 3 regions of the face, and it's motor to the muscles of mastication, the chewing muscles, which are the temporalis and masseter muscle that they've got illustrated on that second picture on the right on your figure on table 13.3. Your facial nerve, mixed nerve, it's sensory to taste, the anterior tongue, and motor to the muscles of facial expression. So both the trigeminal nerve and the facial nerve are both mixed nerves. They're going to carry sensory as well as motor information. Other mixed cranial nerves include the glossopharyngeal nerve, number 9. And like I mentioned, the facial nerve, number 7. Remember, facial nerve is sensory to the anterior tongue taste and motor to the muscles of facial expression, like the muscles allow you to wink and blink and close your eyes, allow you to frown and smile. Those are called the muscles of facial expression, as well as sensory to the anterior portion of the tongue, the taste buds. And then the glossopharyngeal nerve, it's also a mixed nerve. It's going to carry sense information about the posterior taste of the tongue. Most of your taste buds are located in your tongue. So the tongue is going to be carried by 2 cranial nerves, the sensation of taste, both the facial nerve and the glossopharyngeal nerve, number 7 and number 9. And then the motor function of glossopharyngeal would be the muscles of swallowing, the pharyngeal constrictor muscles. The vagus nerve, another mixed cranial nerve. The vagus nerve now will be sensory to the rest of the oral cavity, okay, to taste to the rest of the oral cavity. And it'll be motor to your parasympathetic nervous system. As you can see from the illustration, the parasympathetic nervous system main output is from the vagus nerve, even though you have cranial nerves 3, 7, 9, and 10 contributing to the parasympathetic nervous system. But the vagus nerve will innervate the respiratory system, the heart, the GI tract, the lungs, the liver. Okay. Most of the internal organs, visceral organs of the body, are going to be innervated by the vagus nerve. So it's motor to those particular areas. So this is the overview of all 12 cranial nerves, okay, 1 through 12. And the way you understand these, the position, they basically follow an order. So your olfactory is going to be the most anterior nerve, cranial nerve number 1 for smell, purely sensory, as you can see from figure 13.3. Number 2, optic, Roman numeral 2, vision, purely sensory, takes information about vision, images, okay, and then crosses at the optic chiasma. Then you have 3, 4, and 6, which go to your eye muscles, your extraocular eye muscles, so they're going to be purely motor. Trigeminal, remember, is a mixed nerve. It's going to carry sensory information concerning the face, the upper jaw, middle part of the face, and the lower jaw, as well as your muscles of mastication, your chewing muscles, the temporalis and masseter muscle. So it's a mixed nerve. And then the facial nerve, another mixed nerve. Remember, most of these nerves are going to lie in the area of the brainstem, either the pons or the medulla, except for the olfactory, which is going to be up there towards the, and the optic nerve. These are going to be up there towards the pituitary gland. So facial nerve and trigeminal, those are both mixed nerves. Facial nerve carries sensory information concerning taste in the tongue, the anterior tongue, and also carries information, motor information for the salivary glands. Vestibulocochlear nerve, purely sensory, carries information about hearing and balance. So it's purely sensory. Notice vestibulocochlear nerve number 8 lies in that area of the brainstem, very near the pons and the medulla. Okay. And then the glossopharyngeal nerve is another mixed nerve. Remember, it's sensory to the posterior tongue taste, and it's motor to the pharyngeal constrictor muscles, what we call the muscles of swallowing. And then vagus nerve, number 10, another mixed nerve, it's motor to your parasympathetic nervous system, but it's also sensory to the taste sensation of the posterior oral cavity, all that area of the oral cavity that's not innervated by the number 7 and number 9, the facial and glossopharyngeal. So vagus nerve is another fairly large nerve. Okay, remember the trigeminal nerve is probably the widest of the cranial nerves. Remember, it has 3 roots. Okay, that's what you see coming out of that trigeminal nerve in the very middle part of the pons. It's got an ophthalmic division going to the eyes, maxillary division going to the upper jaw, and a mandibular division going to the lower jaw. And that's how we get the name trigeminal nerve, because it has those 3 little roots coming out of it. And the way you remember where it's located is in the very middle of the pons, on the lateral side of the pons. Remember, the pons is the middle part of the brainstem. Okay, and then you've got your vagus nerve, number 10. Then you've got hypoglossal, number 11, which is motor to the tongue, and your accessory nerve, number 11, is basically goes to the trapezius and sternocleidomastoid. Hypoglossal is number 12. So 1 through 12. 1 is olfactory, 2 is optic, 3 oculomotor, and then you've got 4 and 6, which go to the eye muscles, 5 trigeminal, mixed nerve, 7 mixed nerve, 8 sensory, 9 mixed, 10 mixed, 11 motor only, and 12 motor only. And if you want to remember the mnemonic, you can use the one that you use the first letter of the name. Okay, it's demonstrating these words. You can use the mnemonic O, once, one, takes, the anatomy final. Very good vacations are happening. So O is olfactory, once is the optic, one oculomotor, takes trochlear, the anatomy final, abducens and final, facial. Very good vacations are happening. V for vagus, good for glossopharyngeal. Adducens is R, and then happening would be hypoglossal. So O1 once takes the anatomy final. Very good vacations are happening. And you can use that mnemonic for learning the names of each of the cranial nerves. And then for the function, there are other mnemonics that help you learn the function. Some of those mnemonics are basically illustrated in your lab manual, as well as cranial nerve candy that's posted on Blackboard. There's a condition referred to as trigeminal neuralgia. And it involves chronic pain syndrome involving one or more branches of the trigeminal nerve. Usually patients suffer very intense pain that lasts from a few seconds to a couple of minutes. It's typically unilateral, but sometimes it occurs several times a day. Generally, it's triggered by certain stimuli, like a chewing or light touch, or even vibratory stimuli to the face, like a light breeze may sometimes trigger an attack. But there's really no treatment for it. They've tried non-steroidal anti-inflammatory drugs, and usually the only way to treat it successfully is to sever the nerve, and that eliminates the chronic pain syndrome that people suffer from. So the neurological exam is generally normal, and we really don't know the etiology of trigeminal neuralgia. And like I said before, the effective pain medications are typically ineffective. So the treatment is instead aimed at reducing the aberrant transmission through severing the nerve, usually. Another condition affecting the facial nerve is called Bell's palsy, and that involves the facial nerve, in which the nerve's motor route is impaired by either a virus, a tumor, or trauma. Sometimes we don't know the cause. Patients will have weakness or complete paralysis of the muscles of facial expression because those are innervated by the facial nerve. Paralysis leads to problems with blinking, closing your eye, and making general facial expressions like smiling or frowning. They generally have a flat affect. So other structures affected by Bell's palsy that are innervated by the facial nerve, like the lacrimal gland, the salivary glands, and taste sensation from the anterior tongue. Remember, the facial nerve is a mixed nerve. It's motor to your parasympathetic nervous system, so it's responsible for many of your salivary gland secretions and your lacrimal gland secretions, as well as the anterior taste of your tongue. Rapid onset of symptoms is usually the typical course of experience with most of these patients, and you treat Bell's palsy with anti-inflammatory medications like Lodine and Toradol. Sometimes antiviral medications are applied, like cyclovir. Sometimes physical therapy can be used to alleviate and try to improve the condition. And sometimes surgery may also be necessary for Bell's palsy. Most of the time, people recover function of the paralyzed muscles in about 3 weeks. Sometimes you'll have residuals. So this is a very popular mnemonic. Once one takes the anatomy final, very good vacations are happening. Also remember that you have one nose, so the olfactory is number 1, and 2 eyes, so optic is 2. And then for the function, some say money matters, but my brother says big brains matter more. Okay. Now the spinal nerves. The spinal nerves are short. They divide into 2 mixed nerves, but both carrying both sensomatic motor and sense information. Your posterior dorsal ramus means branch, will travel to the posterior side of the body, and the anterior ventral ramus will travel to the anterior side of the body, or to an upper or lower limb. And so this is the arrangement of the nerves as they exit the spinal cord and enter the spinal cord. So the anterior ramus or branch are fibers to and from the anterior side of the body or the upper and lower limbs, whereas the posterior ramus fibers are coming to and from the posterior side of the body. Always remember your posterior ramus will carry sensory fibers when it basically comes to the posterior root, okay? Whereas the anterior or ventral ramus will carry motor information, okay, as it leaves the spinal cord. These are going in different directions. So this is a structure and function of the root, spinal nerves, and rami. As you can see, the red fibers are the anterior roots, which carry only somatic and visceral motor signals from the CNS, which is the spinal cord, the gray matter, to the skeletal muscles and the gland cells. Okay. Then you have a spinal nerve, which carries visceral motor and somatic motor, as well as sensory signals to and from the spinal cord. And then the posterior root or dorsal root carries only sensory signals from the peripheral system to the spinal cord. And then you have these ramus communicans, which carries visceral motor signals from the autonomic system to organs of the ventral body cavity, like the heart and lungs and GI tract. So the red fibers on the right are your visceral motor neurons, and then the purple fibers are your somatic motor neurons coming from the body. Okay, they're going to the body. And then you have the anterior and posterior rami, also called the ventral and dorsal rami. Those are going to carry somatic motor signals from the CNS to the skeletal muscles and sensory signals from the sensory receptors in the peripheral system to the spinal cord. So if you can look at this illustration, sometimes you get that mental image in your head. It'll allow you to remember which side of the spinal cord is purely sensory, which is purely motor. Okay, always remember sensory information always comes to the spinal cord via the dorsal or posterior side, whereas motor information always leaves the ventral side of the spinal cord. So 31 pairs of spinal nerves, 8 pairs of cervical, 12 pairs of thoracic, 5 pairs of lumbar and sacral, and 1 pair of coccygeal. Okay. And this is how they're organized in the spinal cord, coming out of the spinal cord. So you have your cervical plexus, which are branches from C1 through C5. The main nerve coming out of the cervical plexus is the phrenic nerve, which goes to the diaphragm. Remember, you have 8 cervical nerves, but the cervical plexus is C1 through C5, which means they run together. The brachial plexus include C5 through T1. Okay, and the brachial plexus are nerves that primarily go to your upper extremities. We'll learn the main nerves coming out of the brachial plexus later. Okay, and the thoracic nerves, T1 through 12, those innervate structures mainly in the thoracic cavity. And as you can see, they exit the spinal cord and run between the ribs and the intercostal muscles. They have a posterior side and then a ventral side on the other side. And then the lumbar nerves, L1 through L5, and the lumbar plexus, the L1 through L4. The main nerves out of the lumbar plexus are your femoral, obturator, and lateral femoral cutaneous nerve, which go to structures mainly in the upper part of the lower extremity and the lower abdominal cavity. And then finally the sacral plexus, which are a group of nerves coming out of the sacral nerves, S1 through S5. The main nerve coming out of the sacral plexus, L4 through S4, is your sciatic nerve. Okay, and then the coccygeal nerve is the last nerve of your 31 pairs. So remember, you have a right and left cervical plexus found deep in the neck, lateral to the first through the fourth cervical vertebra. The plexus consists of anterior rami of C1 through C5, and a small contribution from the hypoglossal nerve, which is number 12, crown nerve number 12. Each nerve in the plexus will have sensory branches, cutaneous branches that innervate the skin of the neck, and sections of the head, chest, and shoulders. And then the motor branches will innervate neck muscles. The main nerve coming out of the cervical plexus is the phrenic nerve. It's a major motor branch of C4 with contribution from C3 and C5. So the way you can remember that, the mnemonic is C3, 4, and 5 to stay alive, and then innervate your diaphragm. A hiccup cure that really works, probably the most reliable cure is basically to take your fingers and you try to palpate your cervical vertebra in the back of your neck, in the middle of your neck. Place your fingers about 1 centimeter lateral to the vertebral column on both sides. Apply firm pressure to those muscles of the neck that overlap the phrenic nerve until the hiccup stops. And that's usually about 5 to 10 seconds. And what that does, that pressure interrupts the aberrant impulses that are causing the diaphragm to inappropriately contract. But it's not severe enough pressure to completely stop the nerve from firing, so that it doesn't interfere with breathing. Okay, so the right and left brachial plexus, lateral to the fifth cervical through first thoracic vertebra, those provide motor and sensory innervation to the upper limbs, and they include nerve roots from C1 through T1. The brachial plexus then begins with the formation of large nerve trunks. C5 and 6 form the superior trunk, 7 the middle trunk, and C8 and T1 form the inferior trunk. So these are the trunks coming out of the brachial plexus. So the lateral cord, posterior cord, and medial cord. These come off the superior, middle, and inferior trunks. And then out of the cords are going to be derived your musculocutaneous nerve, which goes to the lateral arm and forearm, the median nerve, which goes right down the median portion of the arm and forearm, the radial nerve, which is the nerve that goes to the first digit and parts of the second and third digits, on the thumb side of the hand, and the ulnar nerve goes to the little finger side, and the median nerve lies in the middle. Now the axillary nerve will be in the area of the axilla. So the axilla, or the axillary nerve, remember these are all branches of your brachial plexus. These are the major nerves. So the posterior cord main branch is the axillary nerve. It serves the axilla, the deltoid, the teres minor, and skin over the deltoid region, and the radial nerve continues off the posterior cord, goes down the posterior arm, innervates your triceps brachii muscle and most of the forearm extensor muscles. It also innervates skin over the posterior thumb, second and third digit, and lateral half of the fourth digit. So on the thumb side of the hand. Musculocutaneous, the lateral cord innervates the anterior arm muscles, including your biceps brachii and skin covering the lateral arm. Median nerve, derived from the fusion of the lateral and medial cords, travels down the middle of the arm and forearm, innervates the wrists and digital flexors. So it's going to be on the middle portion of the hand. So it's going to innervate some of the intrinsic hand muscles and skin over the anterior thumb, your first digit, second and third digit, and the lateral half of the fourth digit. So that's the median nerve. And the ulnar nerve is continuation of the medial cord, traveling near the elbow where it enters the forearm to innervate the flexor forearm muscles, which are not innervated by the median nerve. Also innervates most of the intrinsic hand muscles and skin of the fifth digit and medial side of the fourth digit. So those are what we refer to as the brachial plexus and the main nerves. Musculocutaneous, axillary, and then you have your median nerve, radial nerve, and ulnar nerve. Those are your 5 nerves coming out of the brachial plexus. Now your thoracic spinal nerves do not form plexuses except for T1. So most of each posterior ramus will innervate your deep back muscles, like your intercostals, and each anterior ramus will travel between the 2 ribs as an intercostal nerve, which goes to remember the intercostal muscles are what allow you to breathe, one of the muscles that allows you to breathe. And then the lumbar plexus, those are derived from the anterior rami of L1 through L5. They're anterior to the vertebral. They're embedded deep within the psoas muscle, as you can see from the cadaver view on the right. And then a branch will then innervate the pelvic structures, like the bladder and the lower GI tract, and the lower extremity after splitting into two divisions. This is the lateral femoral cutaneous nerve over here, and the femoral nerve, which eventually is going to go through the inguinal canal, and the obturator nerve, which goes through the obturator foramen. So your obturator nerve is the anterior division's largest member. It enters the thigh from the pelvis via the obturator foramen. It innervates the adductor, thigh muscles, your hip joint, and the skin over the medial thigh. Femoral is your posterior division's largest member, and it's the largest branch of the lumbar plexus. Also travels from the psoas through the pelvis and under the inguinal ligament, enters the thigh where it innervates most of the anterior thigh, muscles and skin over the anterior and medial thigh and leg, as well as the knee joint. So those are the lumbar plexus nerves. Then the sacral plexus are formed from the anterior rami spinal nerves L4 through S4, and they innervate structures in the lower pelvis and gluteal region and most of the lower extremity. And you also have an anterior and posterior division from each plexus. Besides the superior and inferior gluteal nerves, which of course go to the gluteus maximus and minimus, you have the sciatic nerve, which has two divisions, a tibial division and a common fibular division. Okay. Of course, the tibial division will follow the tibial bone, and the fibular division will follow the fibula. Okay. And then you have a pudendal nerve and a posterior femoral cutaneous nerve. But the main nerve is the sciatic, with its two branches, the tibial division and the common fibular division. So your longest and largest nerve in the body is the sciatic nerve, which contains axons from both posterior and anterior divisions of your sacral plexus. Travels through your greater sciatic arch, thus the name sciatic nerve, in the pelvis into the thigh. It passes between the greater trochanter and the ischial tuberosity. It innervates the hip joint and the posterior thigh before it divides into the tibial and common fibular nerves. The tibial nerve is your larger branch off the sciatic nerve. It contains the anterior division of the sacral plexus axons, most of your hamstring muscles, innervates the knee and ankle joint, as well as the plantar flexor muscles like the gastrocnemius. The smaller branches will serve the lateral skin of the leg, as well as the skin and muscles of the foot. And then the smaller common fibular nerve, the other branch of the sciatic, also called the common perineal. Many times we use the term perineal for fibular. These are axons from the posterior division of your sacral plexus. That nerve descends along the lateral leg, supply the knee joint, and the skin of the anterior and distal leg. Then you have a superficial and deep branch. The superficial branch of the common fibular will serve the lateral leg and the dorsum, the top of the foot, and the deep branch supplies the ankle dorsiflexors and two muscles on the dorsum of the foot. So that's that huge sciatic nerve, okay, with its two branches, the tibial nerve in figure 13.9 and your common fibular nerve. And I'm just going to draw those in here. There's your tibial nerve, and there's your common fibular nerve right here. Okay, you can see it's right at the popliteal region. Also, you have distribution of your spinal nerve branches. This figure 1310A gives the cutaneous distribution, the skin distribution of the spinal plexuses, indicating areas of the skin from which the nerves carry sensory information. So you can see the blue area is the cervical plexus. The brachial plexus is that blue area in the upper portion of the anterior arm, upper arm, radial nerve, musculocutaneous nerve, median, and ulnar nerve, as you can see on that anterior division. On the posterior side of the body on the right in figure A, you can see the rest of the distribution. The light blue is the musculocutaneous. The deep red is the radial. Okay. And then in the lower extremity, you can see the lumbar plexus and the sacral plexus on the posterior side. So when you're traveling, when the nerve impulse is traveling from the peripheral nervous system to the central nervous system, stimuli are first detected by sensory neurons. From that point, the stimulus is then transmitted by sensory neurons to the CNS, the brain and spinal cord, where the stimulus is then integrated and interpreted by central nervous system neurons. This process is called sensory conduction, where the stimulus is converted into an electrical signal. So first, the ion channels in the axonal lemma are closed. The stimulus is then detected by sensory receptor. This in turn causes sodium channels to open up. Sodium flows into the axoplasm. Then you get a temporary depolarization. That's called a receptor potential. If there is enough sodium that enters, the membrane potential may reach critical threshold. In that case, the voltage-gated sodium channels open up, and that generates an action potential. An action potential then is propagated along the axon toward the central nervous system, the spinal cord, and the brain. That's called sensory transduction. So when you look at this figuratively in the illustration, figure 1 shows the probe being the stimulus, okay, on the surface of the skin, the tip of the finger, okay, in figure 1311. So before any stimulus arrives to the sensory receptor, the ion channels in the axonal lemma, the membrane of the sensomatic sensory neuron, are closed, as you can see looking at those sodium channels, okay, those voltage-gated sodium channels and mechanically gated sodium channels. So when a stimulus, like a pressure from this probe, is applied, now the mechanically gated sodium channels will open up. Remember, a mechanically gated sodium channel is one that responds to change in pressure, okay? And that causes the sodium thus to enter the axoplasm, okay? And that generates a receptor potential. And if you reach critical threshold, then you generate an action potential. So if you have enough sodium that enters, the membrane potential will then reach its critical threshold, and that causes the voltage-gated sodium channels to open up, okay? And that will trigger an all or none action potential, which will then be propagated along the axon to the spinal cord. So in sensory transduction, you have two types of receptors, rapidly and slowly adapting. Rapidly adapting receptors, like those for smell, those respond rapidly with high intensity to stimuli, but then they stop sending signals after a certain time period, and that's called adaptation. So the receptors detect the initiation of the stimuli fairly rapidly, but they ignore any ongoing stimuli. The other type of receptors are the slowly adapting receptors. They respond to stimuli with a constant action potential, but they do not diminish over time like the rapidly adapting receptors do. Also, you can classify receptors based on their form. Encapsulated sensory nerve endings are surrounded by supportive cells, and free nerve endings like you have in your pain receptors. These lack any supportive cells. Also, sensory receptors can be sorted into classifications based on their location of the stimuli that's detected on the body surface or inside the body surface. Exteroceptors are usually close to the surface of the body. And so this would be true for, let's say, like the thermoreceptors on the skin. So they detect stimuli originating from outside the body. And then the interoceptor is usually found within the interior of the body. And then they'll detect stimuli originating from within the body itself. Also, the type of stimuli that the sensory receptors respond to is another way we classify the receptor, and it causes them to either depolarize and generate a receptor potential. Mechanoreceptors, which are your encapsulated interoceptors or exteroceptors found in your musculoskeletal system, your skin, and many of the other organs of the body, they always depolarize in response to anything that mechanically deforms the tissue, like pressure or touch or vibratory. And that's, of course, that's where the receptors are found. Okay, so mechanically gated ion channels then allow for sensory transduction from vibration, light, touch, stretch, and pressure. Also, the type of stimuli that cause them to depolarize and generate a receptor potential, thermoreceptors or extroreceptors, because they detect a stimulus that's close to the surface of the skin. So most of these are slowly adapting receptors. They depolarize in response to temperature changes. And these will actually separate receptors that detect both hot and cold. You have hot receptors and you have cold receptors, and specific temperature ranges are detected. Chemoreceptors can be either intro or extra receptors. They're going to depolarize in response to, let's say, binding to a specific chemical. Thus the name chemoreceptors, like in the body fluids, like sodium or calcium ions, or in the air. And they generate a receptor potential as your sodium channels open. Photoreceptors, those are specialized sensory exteroceptors found only in the eye. They depolarize in response to light energy, photons. Nociceptors are usually slowly adapting exteroceptors. They're specialized thermoreceptors that respond to a noxious stimuli, like an extreme temperature, like when a person puts a very cold ice cube on your surface of your skin. You experience that as pain because of that extreme temperature. Same thing for a hot object. Capsaicin, there's a substance that's present in many hot peppers called capsaicin. It makes you feel like your mouth is on fire. You can see it in certain peppers. What it does, it opens the ligand-gated channels in nociceptors and triggers action potentials, and that causes the CNS to perceive that chemical as painful. Sometimes a repeated application of this capsaicin to nociceptors, it will desensitize receptors. It makes those receptors less likely to generate receptor potentials in response to a painful stimulus. So capsaicin can be applied as a topical cream to relieve pain of many of your peripheral nerve disorders, like neuropathies that you see in diabetics, or shingles from the varicella zoster, the chickenpox infection, or a viral infection like that's caused by chickenpox. Remember, capsaicin does not do anything to treat the actual source of the pain. It simply makes the nociceptors less able to relay painful stimuli to the central nervous system. Merkel cell fibers, those consist of slowly adapting nerve endings, and those are surrounded by a capsule of Merkel cells. So they're found in your epidermal ridges of your integument, and especially in your fingertips of your hands, where your fine touch is conducted. Receptor potential is generated by mechanically gated ion channels, and they detect discriminative touch. Object form and texture is what we refer to as discriminative touch stimuli. Tactile corpuscles, or Meissner's corpuscles, are deeper in the skin. They transmit discriminative touch stimuli also, but they detect deeper pressure. Ruffini endings are spindle-shaped receptors in the dermis, hypodermis, and the ligaments. Those are mainly refined for stretch and movement. Pacinian corpuscles, they have that layered onion-shaped appearance that you saw in AMP1. They're rapidly adapting receptors found deep within the dermis. They detect high-frequency vibratory and deep pressure stimuli. Also, you have numerous hair follicle receptors, which are basically free nerve endings surrounding the base of the hair follicles found in your thin skin. Remember, you wouldn't find these in your palms and soles because there's no hair there. So they respond to stimuli that cause the hair to bend. And then the proprioceptors. These are only found in the musculoskeletal system. They detect both movement and position of a joint or body part. So thermoreceptor are usually small knobs at the end of free nerve endings in the skin. You have cold receptors. They respond to temperatures between 10 and 40 degrees centigrade. They're in the superficial dermis. And their hot receptors, those respond to temperatures between 32 and 48 degrees centigrade. And they're deeper in the dermis. And then temperatures outside those ranges, those are detected by the nociceptors, which is where you have your That's the reason extremes of temperature are interpreted as pain. Remember, all somatic central neurons are pseudo-unipolar neurons with three main components: the cell body. Remember, the cell bodies of the spinal nerves are in the posterior or dorsal root ganglion, just lateral to the spinal cord. Cell bodies of cranial nerves are in cranial nerve ganglia in the head and neck. Those are, of course, mostly located in and around the brainstem. And then the second component is the peripheral process. This is the long axon that transmits the action potential from the source of the stimulus, like the receptor, let's say in a finger, or to the neuron central process. The central process then will exit the cell body and travel through the dorsal root, where it enters the spinal cord at the dorsal horn, or the brainstem for the cranial nerves. And that's where they deliver their action potentials. So a cell body, a peripheral process coming from the stimulus, and a central process going into the spinal cord. So that's basically how we classify our sensory receptors. Mechanoreceptors. So first, the peripheral process transmits an action potential from the sensory receptor to the neuron's other axon, the central process. The central process then transmits the action potential from the peripheral process to the posterior horn, eventually synapsing on a neuron in the spinal cord or brainstem. Also, sensory neurons are classified by two factors that determine speed with which the peripheral axons conduct the action potentials. First is the diameter of the axon and the thickness of the myelin sheath. The larger the diameter, the faster the speed, as well as the myelin sheath. If an axon is heavily myelinated, you'll have a faster speed because it's more insulated. So your large diameter axons with thick myelin sheaths, they conduct the fastest nerve impulses. Those include axons that conduct proprioceptive information to the CNS, as well as convey discriminative and non-discriminative touch information. Small diameter axons with little myelin will transmit action potentials the slowest. And those include the axons that carry pain and temperature stimuli to the central nervous system. Receptive fields. These are areas that are served by a particular neuron. The neuron with more branches will innervate larger receptive fields. So body regions whose primary function is censoring the environment, like your fingertips, contain many neurons, but with very much smaller receptive fields. Body regions that are not involved in sensing the environment, like the skin of the forearm or the back, those have fewer neurons, but with larger receptive fields. So there's a little test that you can use to determine what we call the two-point discrimination threshold. It's a basic method for measuring the relative size of the receptor fields. So if you look at this illustration, in figure A, you can see the skin of the fingertips has many sensory neurons, okay? And each with a small receptive field. Each one of these is a receptive field, okay? And these would be like in the fingertips, everything where you see these little red marks, okay? But very small receptive fields, okay? So you're going to have more representation in your brain in the primary somatosensory cortex because you have more neurons, okay? Even though the receptive fields are smaller, this will be responsible for a fine discriminative appreciation. And then your forearm skin will have fewer sensory neurons, like you see in the second illustration, okay? And each will have a larger receptive field. As you can see, it covers the area from here to here in the forearm. So you have fewer neurons, but larger receptive fields, okay? So you're not going to get the fine resolution that you would get with the skin, let's say, of the fingertips, where you have many more neurons with small receptive fields. So the two-point discrimination thresholds, where you basically take an object like an EKG caliper or a compass, anything with two sharp or dull points at the end, And then you basically ask the patient to determine if they can distinguish the two separate points, which are usually needles of a compass or a EKG caliper. You bring those closer and closer together until they can no longer distinguish the two separate points as distinct. Okay, and that's the receptive field. Okay, so in the fingertips, the 2-point discrimination threshold is only 3 millimeters because they have very small receptive fields. That's what gives us our fine discriminative touch, which is present in your fingertips. Whereas the forearm, the 2-point discrimination threshold was only 40 millimeters. So it's got a much larger receptive field. Also, skin can be divided into different segments called dermatomes, and this is based on the spinal nerve that supplies the region with somatic sensation. Dermatomes can be combined to a similar dermatome map, except for the first cervical spinal nerve of the sensory pathways to the different parts of the body. But dermatome maps are used clinically to test the integrity of the sensory pathways to the different parts of the body. So this is what we refer to as a dermatome map, okay? And these show you the relative areas of the representation of the different nerves, like the trigeminal nerve, number 5, would be up in the anterior face area, okay? And then you can follow it all the way down to the lumbar and sacral plexus nerves. Referred pain is a phenomenon whereby the pain that originates in an organ is perceived as a cutaneous type of pain. It's like when you've had a gallbladder abscess and your first symptom is pain in your right shoulder. Okay? And that occurs because many of your spinal nerves will carry both somatic and visceral neurons. So you'll have visceral sensations traveling along the same pathways as your somatic sensations are carrying. Referred pain is generally located along the dermatome for that particular nerve. And that's a lot of times how you learn the different signs and symptoms of different conditions. So this is some of the common locations of referred visceral pain, like liver and gallbladder pain would be present in the right shoulder. The esophageal area would be this area in the light blue under the chest. The small intestine is in the mid-gastric area. Appendix is in the right quadrant. Okay. Kidney and ureter, lower abdominal area. Posterior side of the body on the right. You can see the lungs and diaphragm in the upper left cervical region, posterior cervical and shoulder. Stomach in the mid-upper thoracic region. Liver and gallbladder in the right upper, middle, and lower back, kidney, posterior back, and then urinary bladder, gluteal, and posterior thigh area. So anyway, that's basically the big picture of detection and interpretation of somatic sensation by the central nervous system. Now let's look at movement. Your muscular and your nervous systems, those are linked to each other, okay? Skeletal muscle fibers are considered voluntary. They contract only when stimulated to do so by a somatic motor neuron. Upper motor neurons are neurons of your primary motor cortex. They make the decision to move and initiate that movement, but they are not in contact with the actual muscle fiber. Lower motor neurons receive messages from the upper motor neurons. These are in contact with the skeletal muscle fibers. They receive acetylcholine. They release acetylcholine onto the muscle fiber to initiate the contraction. So upper motor neuron referred to your brain, usually, and those neurons in your central nervous system, whereas your lower motor neurons generally receive messages from the upper motor neurons. But the lower motor neurons are usually in direct contact with the skeletal muscle fiber. Lower motor neurons are multipolar neurons. Remember, their cell bodies are in the anterior, either in the anterior horn of the spinal cord or the brainstem. And their axons are in the peripheral system. Motor neuron pools are groups of lower motor neurons that all innervate the same muscle. They're found clustered in the anterior horn of the spinal cord. Large motor neurons are the majority of the neurons within the pools. They're stimulated by skeletal muscle fibers, contract by excitation contraction mechanism. And then the smaller motor neurons are found also within those neuron pools. These are what innervate the intrafusal fibers, those that are part of the specialized stretch receptors, in the stretch reflex, like in those muscle spindles. Okay, remember, muscle spindles contain intrafusal fibers, and then the fibers of the skeletal muscle itself are called the extrafusal fibers. So first, the upper motor neurons in the premotor cortex select a motor program. Second, the basal nuclei enable the thalamus to stimulate an upper motor neuron, the primary motor cortex. Remember, the basal nuclei are the globus pallidus and caudate nucleus and putamen, and then the substantia nigra and the brainstem. Then the upper motor neurons then stimulate the lower motor neurons, as you can see from the red fibers. Okay, then the lower motor neurons then stimulate the skeletal muscle to contract. And then once the muscle contracts, then sensory information then is fed back to the cerebellum. Okay, so the sensory information is relayed back to the cerebellum into the central nervous system. The cerebellum then sends that information to the upper motor neurons to either modify that movement as needed. So your cerebellum basically corrects any errors of movement. Reflex arcs. Reflexes are programmed automatic responses to a stimuli. They generally occur in a three-step sequence of events called a reflex arc. They're usually protective negative feedback loops. First, a reflex begins with a sensory stimulus and finishes with a motor response. The neural integration between the sensory stimulus and the motor response will occur in the central nervous system, either or at the spinal cord of the brainstem. So first, the peripheral nervous system detects and delivers the stimulus to the central nervous system, which in turn integrates the stimulus, and then the peripheral system then delivers the motor response from the CNS to the effector, like contraction of the skeletal muscle. Okay, let's look at the role of stretch receptors in skeletal muscles. These are protective devices that prevent overstretching of your skeletal muscles. So mechanoreceptors in muscles and tendons. These monitor muscle length and force contraction. They communicate that information then to the central nervous system, spinal cord, cerebellum, and the cerebral cortex. Muscle spindles. These are tapered structures found scattered among the regular contractile muscle fibers, the extrafusal muscle fibers. And they're generally 2 to 12 specialized muscle fibers called the intrafusal muscle fibers found within each muscle spindle. Muscle spindles are tapered structures found scattered among the regular contractile muscle fibers. They have contractile filaments composed of either actin and myosin at the poles, and they're innervated by motor neurons. And the contractile filaments are then absent in the central area of those intrafusal fibers. So there's 2 structural and functional classes of sensory neurons that innervate these intrafusal fibers. Primary afferents respond to stretch when it's initiated. Secondary afferent, remember afferent means sensory. It responds to both static length of muscle and the position of a limb. The other type of stretch receptors are the Golgi tendon organs. Golgi tendon organs are mechanoreceptors, but they're located within tendons near the muscle-tendon junction. Okay. So what they do is they monitor tension generated by contraction of a muscle. And they generally cause relaxation of the muscle, whereas the muscle spindles will cause contraction. So a Golgi tendon organ will consist of an encapsulated bundle of collagen fibers attached to about 20 extrafusal muscle fibers. They generally contain either a single sensory axon that fires more rapidly as greater tension is generated with each contraction, and that information has been sent to the central nervous system. So you can see a muscle spindle on the left in figure 13-18. Notice the intrafusal fibers are inside. these fibers that you see on the inside, those are called the intrafusal fibers. Those are outlined in red. And the extrafusal fibers are going to be outlined in yellow here. Okay, here, these will be the extrafusal fibers. And on the right, you have a Golgi tendon organ. And it's going to cause relaxation of the skeletal muscle. And you can see these are sensory neurons. The extrafusal muscle fibers are outside, and this is your muscle tendon junction. Okay, and this would be your tendon on the bottom here, and there's your Golgi tendon organ. So reflexes can be classified by two criteria. One is the number of synapses that occur between neurons involved in an arc. Second is the type of organ in which the reflex occurs. It's either visceral or somatic. Okay, visceral refers to the internal body organs, and the somatic refers to contraction of a gland or an organ or a muscle, a skeletal muscle. Okay, so simplest reflex arcs are called monosynaptic, and they involve only a single synapse within the spinal cord between a sensory neuron and a motor neuron. Your more complicated types of reflex arcs are called polysynaptic, and they involve multiple synapses. So you're going to have more than two neurons. So let's look at first at a simple stretch reflex. This is basically the body's reflexive response to stretching a muscle to shorten it back to within its set optimal length. The patellar knee jacket reflex and the jaw jerk reflex, these are simple stretch reflexes. And these are generally monosynaptic, one synapse. So let's look at the steps in a simple stretch reflex in the spinal nerve. First, you have to have an external force that stretches the muscle. That would be the stimulus. The muscle spindles then detect the stretch. They consist of primary and secondary afferents, sensory, which then transmit the action potential to the spinal cord. In the spinal cord, the sensory afferents then synapse on motor neurons. They trigger an action potential. The motor neurons then stimulate the contraction of the muscle, and it returns it back to its optimal length. So here you can see at the top in figure 1319 a simple stretch reflex whereby the external force stretches the muscle, which is the pitcher of water producing the force on the individual's arm muscles. Okay. Now the muscle spindles will detect this stretch, okay, via the primary and secondary afferents, and an action potential to the spinal cord is then sent. Then, when it reaches the spinal cord, the sensory afferents then synapse on the alpha motor neurons, and they trigger an action potential. And then the alpha motor neurons then stimulate the muscle to contract, and it returns back to its normal optimal length. That's called a simple stretch reflex. Now, Golgi tendon reflexes are polysynaptic reflexes. They're what protect muscles and tendons from any damaging forces. But they cause muscle relaxation, the opposite of a simple stretch reflex action. So when the tension in the muscle and tendon increases dramatically, the Golgi tendon organs then signal the spinal cord and the cerebellum. Those motor neurons then innervating that muscle are inhibited, while the antagonist muscles are at the same time activated. You also have flexion or withdrawal reflex, which involves rapidly conducting nocive afferents, which are obnoxious stimuli, and multiple synapses in the spinal cord. They act to withdraw the limb from the painful stimulus. A cross-extension reflex will occur simultaneously on the opposite side of the body for balance and postural support, while the other limb is withdrawn from a painful stimulus. So that let's say you're walking barefoot and you strike a thorn and that pierces your big toe, your great toe. Well, that'll immediately cause you to withdraw your toe from whatever thorn that has pierced your skin. At the same time, since you're withdrawing your foot, that can cause you to lose your balance. So on the opposite side, the muscles will extend and prevent you from falling so that you can now have basically a cross-extension reflex. Okay. So as you can see from this illustration, when stimulated, the nociceptors, afferents, will transmit the painful stimulus to the spinal cord. And then the alpha motor neurons then stimulate the flexors of the limb receiving the painful stimulus to contract. Okay. At the same time, the hip extensors, because you have the spinal cord interneurons, will basically, the hip extensors of the opposite limb are then triggered to contract, and that will provide tension on these muscles so that you don't lose your balance when you withdraw your toe from the whatever painful stimulus that is faced. Cranial nerve reflexes, these are generally postsynaptic reflex arcs that involve your cranial nerves. The GRAG reflex is triggered when your visceral sensory nerve endings of your glossopharyngeal nerve number 9 in your posterior throat are stimulated. Okay, just putting, inserting a wooden tongue blade can trigger a gag reflex. Corneal brake reflex is triggered when a stimulus reaches your somatic sensory receptors of your trigeminal nerve in the outer covering the eye, the cornea. And something contacts the eye, leading to a blink response. When something contacts the eye, it leads to a blink response. That's called the corneal blink reflex. It is triggered by the receptor of the trigeminal nerve. Also, you have disorders that impact both your sensory and motor neurons of your peripheral nervous system. Those are called peripheral neuropathies. Sensory neuron disorders, the severity depends on which spinal cranial nerve is involved. Lower motor neuron disorders, those usually result from injury of either the spinal or the cranial nerve, or injury of a lower motor neuron cell body. And that prevents motor nerves from initiating the skeletal muscle contraction. Plantar reflex, normally you should see the toes flexing in the downward direction as you see in figure A in 13.21. Okay. Whenever, let's say in figure B, whenever you stroke the sole of the foot, let's say the hallux, the big toe, will extend and the other toes will splay out. That's called a positive Babinski sign. That's generally, whenever you see a positive Babinski sign, that almost signals pathology in an adult. It does not signal pathology in an infant because myelination is not completed in development of the infant's nervous system yet. So you never look at a positive Babinski sign as being pathogenic in a child, okay, or an infant up to about 18 months. But it's always considered a condition of an upper motor neuron disorder in an adult whenever you see a positive Babinski sign. Okay, so it's present in adults with upper motor neuron disorders like brain tumors. So upper motor neuron disorders impact neurons of your CNS, so they're not considered peripheral neuropathies. They can result from damage or disease anywhere along pathways from the motor cortices, from the primary motor cortex and the pre-central gyres, or the primary somatosensory cortex and the post-central gyres to the spinal cord. They can occur anywhere along the pathway from the motor cortices to the spinal cord. Your body's initial response to upper motor neuron damage is spinal shock, and it is characterized by paralysis. And that's believed to result from the shock that is experienced by the spinal cord circuits when that input from those upper motor neurons is removed. After a few days, the spinal shock will wear off and spasticity will develop. That's characterized by an increase in stretch reflexes as well as an increase in muscle tone. That phenomenon is referred to as clonus, which is this alternating contraction relaxation period of your skeletal muscles. Sometimes people confuse this with seizures. Spasticity is probably due to the loss of the normal inhibition that's generally mediated by your upper motor neurons. The Babinski sign will also develop in upper motor disorders, and that's elicited by stroking the bottom of the foot. You can use the handle of your reflex hammer if you want. A healthy adult will flex the toes, and that response is called a plantar reflex, where they go downward. A patient with upper motor neuron disorder will extend his hallux, his big toe, and splay the other toes. A positive Babinski sign is often present in infants up to 18 months old and does not signify pathology. Same response in an adult, though, is always considered abnormal. ALS, also called Lou Gehrig's disease, involves degeneration of your cell bodies of your motor neurons in your anterior horn of your spinal cord, as well as upper motor neurons in the cerebral cortex. The cause of the degeneration is not known at present. It's likely multifactorial. We know there's a genetic component as well as exposure to certain viruses. The most common early feature of the disease, though, is muscle weakness, particularly in the distal muscles of the limbs and the hands. Over time, the weakness spreads to the other muscle groups, and then you start developing your upper motor neuron symptoms. Will start developing. Death typically occurs within 5 years of the onset of ALS. In most forms of ALS, cognitive functions are spared. The patient is generally fully aware of the effects and complications of the disease. Stephen Hawking, he had ALS, and he was treated for years, even after he was first diagnosed at Cambridge. Although intensive research efforts are ongoing, there's actually no cure or treatment that prevents progression of ALS.